Now, there is this one important clue in this question. Remember that you don't have to focus on this. Oh my God, I don't remember anything about this. When you see this in the question, the most important clue given here, there's a crush injury. Whenever there is crush injury, you always think about the rhabdomyolysis, right? Crush injury, rhabdomyolysis, important, right? Now, let's have a look at this urine plasma creatinine ratio. So, basically, we are distinguishing between pre-renal and intrinsic renal AKI. So, look at this one. Understand, this is very, very important topic for all the exams. Pre-renal AKI and intrinsic or the renal wala AKI. Now, in pre-renal AKI, the causes before the kidney, that means it's hypovolemia, heart failure. So, in that case, what is the kidney going to do, right? It will retain the fluid, right? It will retain sodium, it will retain the fluid, it will retain the urea as well, right? So, the fractional excretion of sodium in the pre-renal one is going to be less or more. Excretion of sodium, right? So, it is going to be less or more. FeNA is going to be less in pre-renal. Similarly, Fe or excretion of urea is going to be less. There is increased reabsorption that you see here for sodium and urea. Okay, both of them. Right, clear with everyone? So, the urine sodium is also going to be less. So, how is the urine specific gravity? We are retaining the fluid and everything here. So, the urine which is going to be concentrated urine. So, the specific gravity is more in the pre-renal one, right? It's a concentrated urine which is going because we are reabsorbing all the fluid. The urine osmolality is going to be more because the fluid is what we are trying to absorb more. Now, urine to plasma creatinine ratio and the plasma BUN creatinine ratio. What is happening here? Remember, both of these ratios are high. Okay, urine plasma creatinine ratio and the plasma BUN creatinine ratio, both the ratios are high here, except for these fractional excretion ratios, the percentage that you see are less. The rest of the two are going to be high here. Okay, the rest of the two are going to be high here because here there is increased urea absorption which is happening. The BUN creatinine ratio is more. Okay, so that is what you need to remember here. Now, in ATN, this ratio is going to be less. Rhabdomyolysis is a cause of ATN, tubular necrosis, intrinsic cause. Okay, so this is what is the intrinsic cause here, and that is why your congestive heart failure, hypovolemia, both mean the same type of AKI, and automatically both these options are wrong, right? UTI is not a intrinsic cause here again. So that is why, remember that the answer here is rhabdomyolysis. Remember, in pre-renal AKI, the urine osmolality is high, the urine specific gravity is high, right? Your FeNA and even your Fe, fractional excretion of urea, is decreased. Okay, that is decreased. Rest all are increased. Urine specific gravity, urine osmolality, urine plasma creatinine ratio and plasma BUN creatinine ratio, all of them are increased except your fractional excretion of sodium and fractional excretion of urea. Is this clear with everyone? Right, rest everything are more. Rest everything are more except for this fractional excretion. Okay, at least remember this. In pre-renal, fractional excretion is decreased, rest everything is more. Okay, it is increased. Okay? Clear with everyone? This is a very, very important table, and you get this questions in almost all the exam. Pre-renal and intrinsic or intrarenal AKI. Yes. Absolutely right, SRR. That's the concept behind ATN. And remember, in ATN, you have this epithelial cell cast, while in the pre-renal, there are no cast because the kidney per se is not affected. In intrinsic, the kidney tubules are affected. There is necrosis happening. Epithelial cast is what you are going to see here. ठीक है